So welcome to our live stream. This patient is from Canada. Excuse me. It's March 2nd, 2023. She traveled here because she's had chronic back pain for a long time in two spots. One of those spots is at L2-3, the other is at L5-S1. She has two herniated discs, one at L2-3, one at L5-S1. Her pain is on the right side, shooting down the right leg. Now, she's already had surgery done, unfortunately. You can actually see that. Go back, show us in the lateral view the metal implant that was put in. All right, see the metal implant, folks? This is called an interspinous device. Interspinous device. They're being put in left and right by shady, bad doctors all around the world. They don't work, but they pay well. Patients end up needing more surgery afterwards, just like she is. And I would never put one in a patient unless I really hated that person for some reason. But there's no good reason to put an interspinous device in. They don't work. And they cause surgery and unnecessary harm to the patient. So we're actually going around the device, and we're going to go fix the actual problem, which is the annular tear and the herniated disc at L5-S1 first and then L2-3. We're also going to do a Deuk plasma rhizotomy at L2-3 where we know she has facet joint pain. Alrighty, so any questions, feel free to ask me. Is she reliable? Let's show the tip of the needle at 5-1. I'm right at where the herniation is. I can feel it. Show us, you can actually kind of see the herniation there. Yep. And then show us where the nerve root is, above. So the nerve root is just above the needle. Are you having any pain? All right, doing great. Dr. Deuk here. We started the surgery, and we just needed to know from you how you're doing, okay? All right. You're doing great. So that went in easily, which tells me that's a big herniation, a big tear. Now, let's see if I can get 2-3 from the same incision. I don't think I can. Right? 5-4-3-2. There's no way. Maybe I can. So let's go north a little bit. You're doing great. Just go back to sleep. Let me know if you're having any pain, okay? All right. So there's 5-4-3-2. I'll make one attempt. Yeah, one attempt to do it. I make an incision. I don't know if I can get L2-3 with the same incision, but I am going to try. If I can't, we'll have to do a second. Shot. 5-4-3-2. Let's put some num-num. We're going to give you some numbing medicine to make it more comfortable. This is a little bit of lidocaine and marking.
Perfect. Relax. Take some nice, slow, deep breaths.
All right. That's it there. 5-4-3-2. Might actually, I don't know. I don't think so. I don't like the angle. I'm just going to go up higher. You've numbed here?
Yep.
Shot? That's too high.
Keep your hands still.
Shot. You're fine. Everything's okay, I promise. 5-4-3-2. Let's give some more numbing medicine. So if you have questions, feel free to type them up. I'll do my best to answer them. In the meantime, while we're accessing these herniations with the needle, let's go ahead and show the audience why does a herniated disc actually cause back pain? What's the mechanism? It's inflammation, but we want to show you why and where.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. At this point, we're getting ready to access the L2-3 disc. I'm just a little lower than I need to be. Give me an AP. So remember, we're fixing two discs. They're both from the right side because she has more right-sided back and leg symptoms. We're also going to be treating an arthritic, painful facet joint at the same time. Yep. You can see the implant. Show the implant that was put in her last surgery over in Canada. She had an implant put in. Yep. All right, let's go back to the other view. Give me a lateral view. And once again, my thoughts on the implant, those interspinous implants are no good. They don't work. In her case, it helped for, I think, a little while, but I don't think it was the implant that helped her. I think it was having a procedure done in that area that may have helped her temporarily. Shot? You doing okay? Shot? Trying to get a little bit higher up. Shot? That's better. All right. Now, 5-1, I think I might want to, let's see. I think we might be okay at 5-1. All right. So, folks, when I asked her, where do you have back pain? She told me I have back pain here, in this area, as well as over here. There's really two damaged discs. One is the L5-S1, and the other is the L2-3. You can see it on the MRI. The 5-1 is worse structurally, and I believe both of them are actually causing her symptoms. Are you comfy? No pain? How bad is that on a scale of 1 to 10? What's the highest? 10. Is that where you typically get back pain? That was your disc, by the way, at L2-3. So that disc is definitely causing back pain for you. It was a 10 out of 10. She said, ow, 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 ow. And I said, how bad was it? She said it was a 10 out of 10. She knows the routine. She's watched some of these. So I'm glad we're fixing that one because it's definitely causing pain for you. All right. Is it better now? Okay, good. Pain's gone?
Pain's gone, Tom? Yes.
All right. Shot? How bad is that? How bad on a scale of 1 to 10? The highest amount was 8? Is that where you typically get back pain? AP? All right, that's your L5-S1. The highest was an 8, correct? All right, so we've got 10 out of 10 concordant L2-3, and we have 8 out of 10 concordant L5-S1. All right. So I'm going to have to play a little bit with L5-S1 because we're a little bit lateral. I need to be more medial. So I'm going to do something. You're okay. That's just the medicine going in your arm. I'll start at 5-1. You're doing great. Everything's okay. That's just medicine going in your arm. All right, so I'm going to actually use the guide wire to bring the dilator down to the back of the disc. Shot. Let's take a look at 5-1. Shot. All right, so the guide wire is in. You can see it. Show us the guide wire. That's it. All right, so at this point, we're inside the disc at 5-1. Try not to move. All right. You okay? All right. I need you to count from 1 to 100 out loud while we put you to sleep. Start counting. Count in Canadian for us. Out loud. All right. Let's go ahead and show our audience how we do this procedure with the video.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. We're just placing the first dilator and tube at L5-S1. I need you to... Dilator's pulling back a little bit. A lot of pressure down here. This is a very inflamed disc. Shot. That should be good. Let's see where that is. We're going to do the whole surgery through a small tube. It's called an endoscopic tubular retractor. I'll do that. All right. Thank you. Any questions about the surgery so far?
No current questions.
Sometimes people ask, why do you do these surgeries? The purpose is to get rid of back pain and leg pain that comes from a herniated disc. The surgery is only going to fix pain from a herniated disc and nothing else. So if you have a patient who doesn't have a herniated disc, laser, then you're not going to be able to fix their pain if the pain is not coming from the herniated disc. So that's the most important criteria. Look at that inflammatory tissue right there. That's pretty good. See all that pink tissue in the annular tear? All right.
Yes, we do.
For her, I have to do more of an outside-in technique at 5-1. This is the herniation, but I'm starting more superficial in the disc. In other words, the word superficial in medicine means closer to the surface. So I'm starting closer to the surface in that disc at 5-1. And the reason is that her anatomy does not allow me to get more medial and more deep. Her facet, probably her scar tissue from her prior surgery, it's pushing me laterally in my approach to the 5-1 disc. So I'm having to start on the outside near the outside fibers of the disc rather than deep inside the disc where I normally do at the deep annular tear. So the annular tear starts in the inside of the disc and goes to the outside. Luis, it's just not, can you switch with Oscar for this? He's just not holding it properly. I'm not sure what he needs to do. All right. That's better. And as I was saying, we like to ideally start the procedure inside the disc, just inside the wall, the torn wall, called the annular tear. And if you think about the annular tear, it starts on the inside and works its way to the periphery or outside of the disc. So inside of the wall to the outside of the wall. And we like to start on the inside of the wall. But I couldn't do that for this one because her anatomy, her facet joint, her scar tissue, it all blocked me from getting to the inside. So I'm starting more on the outside. All right. Grab her. See the herniation staining blue. And oh, the other thing that affects your ability to get medial with your tip of your tube is also the pelvis, the iliac crest. So that's important too. It forces you, if you have a narrow iliac crest, it forces the tube to go more laterally, which is where you really don't want to go. But I think we're going to be able to get done what we need to get done here. But L5-S1 is always the hardest if you're doing endoscopic surgery. It's always the big question mark. How much can I really get done at L5-S1? Is it enough? The other discs are fairly easy to get everything done because you can approach them from a more lateral trajectory, whereas at L5-S1 restricted by the patient's iliac crest. Anyway, what you're seeing there at 3 o'clock is the vertebral body. It is bone. It's a bony structure. And it can only be bone itself can be removed with the laser as needed. So the problem here is we got the nerve root just up there, very close, and I'm trying to get as much of this herniation at 5-1 as I can get, but I'm limited by the structures. Now that's interesting. There's some, she has a variation of a normal nerve right there. You can see it at the top. I just showed it to you. That's a branch coming off the L5 nerve root going down towards the S1. So some people call it a Furcal nerve. I just call it a branch. But we just want to be careful not to damage it at all. It's right at the top. See the white thing there? Not what I'm touching, but just above. That's it. So again, I'm finding that I'm limited in what I can do by her anatomy. And that's always how surgery is. Surgeons are always going to be, we call it constrained. This is all scar tissue here. So the more of this I can get out, the better she's going to feel. You can see the little vein up there, the red thing at 12 o'clock. Okay. I'm trying to reach medially and grab, grab more. How's she doing?
Doing well.
Yeah,
Doing a lot of pressure.
wonderful.
Stats are
Huh?
good. Stats are good.
Good. Let's get the laser back in. All right, so we're going to finish the L5-S1 soon because we're doing as much as we can safely. And I think that's going to be enough to get rid of her pain down here at L5-S1. Then we're going to go to the L2-3. And then after that, L2-3, Deuk laser disc repair. We're going to go to the DPR. Questions from the audience? Anything?
No current questions.
Now the sides of the laser are safe. It's just the tip is where the energy is directed. So if you're wondering, well, can that laser, see the blood vessel right there? I'm right up against the blood vessel. And I'll turn it on. You can see it doesn't damage the blood vessel at all. The laser, the business end of the laser is the tip of the laser. So you can use it very safely and very precisely in spine surgery. And it's all FDA approved for use in spine surgery. I need about another minute here. The other thing is, as I'm forcing my tool to go look more medially, okay, as I'm aiming more towards the center of the disc, as you can see, I'm able to get a little more, shave off 0.5 millimeter every time. I'm not putting pressure on the scope, okay? If you put pressure on the scope, you're going to end up you're going to end up breaking the scope. So she does have a split nerve at L5. I can't get any more medial. This is the most I can do here safely. That other surgery, I think, really hurt us because that piece of metal that's in there is sort of blocking my access from all the scar tissue. I can't get more medial, which I want to be more medial. I want to get all that blue stuff there, but I can't reach it. Like I said, I'm not going to jeopardize her nerve. Already the nerve is stretched a little bit, so she's going to have probably some symptoms related to that, but I'm not going to transect it. That's as far as I can go. You can see how I can get almost 0.5 millimeter at a time, right? And again, don't put any pressure on the scope. Put it on the tube. If you're doing this kind of surgery, if you put the pressure on the scope, you'll break it. So I'm touching my tube, and I'm literally pulling my tube as hard as I can, safely, to get and look more towards her middle, where the herniation is, and chop out as much of it as I can. All right, we got about a minute left. This is all scar tissue from the herniation, the white stuff. The more of that scar tissue I can remove safely, the more, we call it debulking of the herniation I do, the more volume I can take away from the herniation itself. You're never going to get all the herniation. Everybody wants to look at their MRI afterwards. I tell them, sure, you can, but it's not going to tell you anything. All right, let me see if I can grab any more out. So I'm using a combination of laser, vaporization, and then, of course, a more traditional tool, which is called the pituitary rongeur. I wonder if I can use a Grabzilla. Why don't we get a Grabzilla in here? I'm going to try to see if I can get a little more with Grabzilla. Who's getting Grabzilla? Again, every 0.5 millimeter I shave off is just that much more room for the nerve root, and it helps. You have Grabzilla?
Yes.
Little bone edge here. It's a little bone spur, in case you're wondering. That's what bone spurs look like. All right. Let's try Grabzilla.
Can we turn on the light, please? Yeah. Go ahead and turn on the light, please. Thank you.
Thanks. So Grabzilla is a pretty aggressive pituitary designed for reaching as medial as we can. Yeah, that was a nice one. And pulling out pieces of herniation. The way it works is quite fascinating. It actually reaches underneath the annulus and pulls herniation from under the annulus that's more medial than what you can get with the other
Thank you.
device. So all right. Well, you can see we got into some of the flesh of the herniation there. Nice. That should help quite a bit. And then I'll augment what Grabzilla does, because it's always going to pull some more herniation towards us and make some more of the herniation more accessible to the laser. Any questions?
No current questions.
All right. Let's see. I'm going to try to take a little more. Again, don't pull on the scope. You'll break the scope. Just pull on the tube. See how much more movement we've got now? I'm able to pull further lateral because the tip is able to go more medial because we've removed some of the scar tissue that was blocking it. This is all, that white wall right there I'm working on is scar tissue. That's from the herniation, from the base of the herniation, the beginning of the annular tear deep inside. Remember, the disc has 25 layers of collagen making up the annulus, 20 to 25 layers. And so the innermost layers are what you're seeing down at the bottom there. We're now right here in the outermost layers. So from innermost to outermost, it's like an onion. And this thing was torn a long time ago. This patient's been suffering with pain for a long time. Notice how I'm staying underneath the nerve. The nerve is right there, that white thing, you see the edge of it? So I'm staying underneath it. That way I'm not going to damage it with the laser. Just underneath it, literally just millimeters. Yeah, she doesn't like that. Because it is painful. All right. Let's see if I can get any more. And then we're going to call it a day on this disc and move on to 2-3. And it looks like 2-3 is the more painful disc anyway. And the 2-3 facet as well. So look at that, just thick wall of scar tissue. Let's try the Grabzilla one more time. Right here at this spot. See if we can get some more of that. Definitely working. That was a good bite. What we call bite in spine surgery is when you're using a device that actually comes together and bites tissue. We call it biting. Of course, we're not really biting anything with our teeth, but we're biting with a surgical instrument. Part of having you here for the surgeries is so you can learn the lingo of what spine surgeons use during surgery. All right. Henry, what other video can we show our audience? Anything?
We have the what is a microcystectomy video.
Why not? Let's show them what they shouldn't do, which is a discectomy, laminectomy. A very bad surgery indeed.
A large incision is made. Muscles are torn from the spine. Substantial bleeding occurs due to muscle trauma. normal healthy bone is removed to access the herniation. Stabilizing ligaments are removed in order to access the herniation. An incomplete portion of the herniation is removed. Dense scar tissue forms. Weakened bones can fracture, leading to instability and pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back. We are Dr. Deuk Majin here. Oop. What happened there? Was that just ran out of liquid? All right. Light on. All right, we're done here. And I tell people there's still a little bit left there. I would say we probably got 50% of this one. Let me have the grabber. I'll just try the grabber. I tell people we need to get 50% to get rid of the symptoms. And I'd say we're just at 50% or slightly better than 50%. And I can't get more just because of her anatomy. Everything okay?
Looks good, I mean.
Yeah. And this is so scarred up. Ooh, maybe I did. All right, there we go. Hold that. Yeah, we just got a nice chunk out. Oh, yeah. Maybe another chunk right there. There we go. All right. This is a really, really old and scarred herniation that I'm now literally, I just got a good grab on it, a good bite on it, and I'm able to start teasing some of it out just as I was about to stop. So I think this is going to help her more. But you see how white and thick and strong and tough it is? I'm pulling on it, I could tell you right now. It is a really old herniation, full of scar tissue. That's what all this white stuff is. This is at least 10, 15 years old. At least, maybe even longer. And this is what she had her surgery for back in Canada at L5-S1. Yeah, I think it was just dry, right? We hit a dry spot. Anyway, the surgeon that did her surgery with the interspinous device didn't treat the actual source of her problem, which is this old herniation. But we're doing that now. You may ask, well, why didn't they treat the old herniation? The answer is they're hard to get to. It's very easy to do an interspinous device. And even in the United States, doctors that aren't even spine surgeons are now doing spine surgery, but you don't see them doing the really good spine surgeries like this because they're too difficult for them to do. They don't know how to do these kind of surgeries. These are far more technically challenging. Technically challenging procedures are what surgeons do. If the procedures were not technically challenging, everyone would do them. Non-surgeons would do them. But the more difficult things in medicine to do technically are done by specialists. And the specialists that do surgery are called surgeons. And the problem is in the United States right now, you have a bunch of doctors who are not surgeons that are trying to do surgery because it pays them a lot of money, a lot more money than they would make if they were just not doing surgery. A non-surgeon pain management doctor may make $2,000 a day not doing surgery. Then when they start adding surgery, they could make $10,000, $20,000 a day. So they're trying to do surgeries even though they shouldn't be. The problem is their surgeries are not good. They're not technically good. They don't do a technically good job. So they do bad surgery, and the patients don't know, because then the doctor's not going to say, hey, I'm not a real surgeon and I really shouldn't be doing this on you, but I'm doing it for the money because I want to make a lot of money. So the doctors don't tell the patients the truth. They just tell them, hey, we can do surgery, maybe it'll work. And the patients don't know any better, and they think, okay, well, you must be doing what you're supposed to do. They trust the doctor. But then there's no oversight. There's no proper oversight for those doctors doing things they shouldn't be doing. All right. Well, this is taking me a lot longer than I expected because of the amount of scar tissue there is here. And I'm just going to try one more. And I want you to look at something with me in just a moment right here. I'm going to show it to you. I just want to finish this. And I'm going to show you what I'm seeing. And it's important to see it. Okay? Look right, hold on. Look right there. I can't see it right now. I saw it a minute ago. But there was a space underneath the nerve. Right there. And that space was showing me that nothing was touching the nerve anymore, which means the herniation is off the nerve, which means I got enough of it out. What's blocking right now is that ligament. That's called the foraminal ligament. And I tried zapping it right there. But I could see a space right where the ligament's coming out underneath the white thing. The white thing is the bottom edge of the nerve. The blue is what's left of the herniation. And that's a blood vessel, a vein, and there's a little bit of ligament right there. Okay? But there was a gap there, and it showed me that basically at this time, there's space between the disc herniation and the nerve. So I've done the best that I can do at this point, and I feel good about it. We've debulked the herniation here at 5-1. Gotten rid of about 60% of it. And I just can't get any more of it out. So I'm not going to stay here all day to get 5 grains out. We've done everything we can do safely. Okay? And things are moving a lot better now. More normal. Of course, I would love to stay here for hours doing this, but it's not good for the patient to keep them under anesthesia for too long. And I don't see any way I can get around the nerve that's sitting there right behind the disc herniation. And there's a little vein. You guys see the vein? Look how the laser is touching the vein, but it's not doing anything. That's because only the tip of the laser is the part that actually does anything. Done.
Right palm, please. Right palm.
Good. One down. We have one more to go, and then we have the DPR for the facet pain. Hello. Yep. Questions?
No current questions.
No questions?
Nope.
Okay.
Do we have the roll? Thank you.
Now also I tried to do one incision for both discs, but I couldn't. So we are going to have to do a second incision for the second disc because it's so far away from the first one. Taking the tube out. We're going to bring the X-ray machine back in so I can navigate to the L2-3 disc. Our patient is comfortably sleeping. There's no tube down her throat. There's no general anesthesia. She's just twilight. Basically sleeping, but without any type of airway device. Just a face mask with oxygen support and monitoring. So it's nice not having to do general anesthesia. It's much safer for the patient. Okay, you can see now we're 5, 4, 3, 2, 2, 3. Huh? Shot? A little more. Shot? Perfect, done. Here, you gotta hold this. Okay, let me take care of this. Okay. Shot? Good. We're going to do another stab incision just next to this guide wire, 7 millimeters. It's called a stab incision because you stab in as opposed to a different kind of incision where we make a line, a linear incision. It's called linear. Linear is obviously line in Latin. Linea.
We have a question.
Sure.
This comes from Carla on YouTube.
Hi, Carla. Thanks for joining.
And they asked, for cervical herniation Deuk laser surgery, you put the patient to sleep, correct? How do you test the painful disc like you do when you do the lumbar surgery?
Carla, great observation. I love it. So Carla made a great point. She said, when you do the cervical DLDR, the patients are completely asleep with anesthesia. How do you do a discogram, evocative discogram? We do a discogram shot. We just don't do an evocative discogram. We're not evoking a pain response. And that's because the patient has to be asleep. The reason the patient has to be asleep for cervical is, number one, we don't want them moving around while we're operating above their spinal cord. Number two, I can't get to the part of the neck I need to, the spine, safely with all the muscles in the neck contracting. So the only way to keep the muscles from contracting in your neck while I'm doing the surgery is to paralyze the muscles chemically with a muscle relaxer, it's called, neuromuscular blockade. So basically, if you're going to give somebody neuromuscular blockade to make the muscles not contract so I can do the surgery, they can't breathe anymore. Their skeletal muscles will be blocked as well. So basically, the only way to safely do the cervical surgery is to make the patient with complete neuromuscular blockade, and that requires a tube to be down their throat to ventilate for them. They have to be on a ventilator. But yeah, we don't get an evocative discogram in the neck, ever. And, you know, the truth is, to be quite honest, if you look at all my discograms I do, have you ever seen one of my discs not be painful? They are painful.
Thank you.
They're all painful. That's because I'm really good at picking which discs are causing pain. That takes a lot of years of practice and experience. So we don't need to do, or we cannot do, an evocative discogram in the neck. It's not safe and not appropriate. By the way, look at this herniation here. This is newer. This is a newer herniation. There's not as much that really thick scar tissue. It's more of the fluffy blue disc. So this is definitely a newer herniation, probably a few years old, maybe at most. It could be that she tore this, first years ago, and then there's some new blue stuff now that's new herniation, recent herniation. Okay? Can actually see some of the normal architecture of the annulus fibrosus right there. Some of the crisscross fibers. You see the crisscross fibers right there? It's a little bit overexposed, but everything looks very white. But if you can turn it down just a smidgen, you can maybe see that. Click it down just a little bit on the light. There you go. That's better. So you can see some of the fibers right there of the annulus. Here's the tear. You see the crisscross fibers right there?
Yes, we do.
Yeah. So the normal lumbar disc has about 20 to 25 layers of that. This is all herniation right here. So I've got to take some of the annulus down in order to get to the herniation. All this blue stuff is bad, degenerate. It's like a rotten apple core. You want to remove as much of this rot as possible in order to let it heal properly. All right. So far, the surgery is going very well for the patient. Here's a little bit of scar tissue from an older injury. So you can actually see different areas of the herniation have different ages. This blue, fluffy blue stuff is recent. The more stuck together blue stuff, like right here, is older. And then the really stuck down stuff with a thick white scar tissue is really old, 10, 15, 20 years old. So you have a mixture of different age injuries. It's not one injury, you know? It's kind of like looking at an old city in Europe. If you ever go to Europe and you go visit the castles, you know, and you see that they've had damage to them from many years of wars. Well, some of these castles are thousands of years old, and they've been through 5 or 6 wars or battles. And if you look at the damage on the castle, you can actually tell how old it is, because when they repaired the castle, they repaired it with the materials that were available at that time period. So the repairs done, you know, in 2,000 years ago are going to look different than repairs done that are more modern repairs with steel, you know, metal and steel. And, you know, maybe you'll see some wood repairs from a long time ago. You'll see some stone repairs, but you'll see some brick repairs, because the brick started becoming popular 100 years ago, and when brick technology. So you can actually see these castles show you, there's a tear right there in herniation. They show you different ages of battle scars that were repaired at different time periods in life. So you can't look at a castle and just say, oh, yeah, it has all that destruction. That was all from one time. It's not from one time. It's from 5, 6, 7, 10 different attacks. So the disc is the same way. There is no disc herniation that I've ever seen that's been a one-time event. It's extremely rare. Typically, people get a herniation, they get horrible pain, it lasts for a few weeks, they put it off and they don't do anything about it. They just wait for it to kind of feel better. They don't go see the doctor, and then of course it gets better symptomatically, but it doesn't ever heal. And then of course they have a weak area now, a weak spot that is easy to re-injure. And that tear opens up again the next time they do some sports activity or anything like that. And thanks. And basically, as you keep re-injuring the tear, now let's see here. This is kind of neat. You can see the tear and you see the pink stuff, okay? The pink stuff is the granulation tissue. So let me do something here. Let's try to get a good picture, Henry, on this one. Let's just see what we can do. Let me see if I can focus it. How does that look? Good?
Looks good to me.
All right, can you get a little picture
I
there?
already did.
All right, you can see the pink material. That's the granulation tissue. Now, of course, over the years, in the future, people are going to start talking about this more, and other doctors are going to mention it. But understand, it came from here, Deuk's spine. We were the first ones to show it and describe it. But like all good things in life, everyone else will try to claim it and take the credit for discovering it. All right. Any questions?
No current questions.
And we shall press on. I think I got 5 minutes. Then we got the DPR. Yeah, it's kind of a mess in here, but definitely a much younger herniation than the last one we just did at L5-S1. This stuff here is about a year old. This right here is probably 2 or 3 years old. See the calcium in there? Oof. It's pretty bad disc injury though when you think about it. Now some of you may be looking and saying, oh my gosh, you're taking the whole disc out. I'm not. This is literally a small area of the disc. The sides of that metal from left to right, side to side, is about 6 millimeters. So think about how small that is. 6 millimeters is not very big. There's still a whole lot of disc.
We have another question.
Sure.
This comes from Sean Wilson on YouTube. And they asked, how many surgeries do you do a week? And are you the only doctor who does the actual surgery?
Hi, Sean. Yes, I am the only surgeon that does the actual surgery. I'm a neurosurgeon. And we do anywhere between 2 to, maybe 8 a week. Just depends on the volume we get. We are able to do a lot more, but a lot of people don't know about this treatment. So I think we would be busier if more people knew it was available. Thanks for asking. All right, now just so you understand the orientation, I'm looking sideways here. So I'm gone from looking towards the tears, just so we all understand, the tears run from the middle to the side, okay? Medial to lateral, we call it. Medial to lateral. This is all part of the tear. And there's the blue stuff is the herniation stuck in the tear. So that's the bad stuff, okay? And we've gone from medial to lateral. So now I'm looking more medial towards the midline, towards Luis, so to speak. And before I was looking more lateral. Look at the crisscross. There it is. That's beautiful. Let's take a picture of that because that shows a normal annulus. This is important. Put this picture into my special category. All right? Take a couple. Take like 4 of them. I'll move the tube just a little bit so you can see it. But can you guys see the detail of the fibers? Now, here's the beauty. Look at that blue thing. That is the tear. And that blue stuff is the herniation in the tear. Okay? So this is a really important picture, Henry. I want to keep it for the publications. All
Copy
right?
that.
Get a bunch of them. All right? Get a bunch of pictures. Like, 10 of them would be okay. I don't see the crisscross patterns very often.
Copy that. And we have a question.
Sure.
This comes from Stacks on Facebook. And they ask, what's actually happening in the video?
All right, why don't you run our Deuk laser disc repair video again so that people can understand what we're doing. Show you, Stacks.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
We're just talking about the train crash in Greece that happened yesterday. killing almost 50 people, or maybe even more than 50 people at this point. The person in charge at the station of switching tracks was asleep at the job, or whatever, you know, on drugs. They say asleep, but who knows. And basically did not switch the two trains. And a passenger train just outside of Athens collided with a transport train for equipment, and head on, and people have died, and it's horrible. One human's mistake. I honestly feel like that happens every day in the spine surgery world, because these surgeons are hurting people every day with their not doing their job right. Okay, we are just about done. The rest of this stuff looks good. I'm leaving the good stuff behind. All done. The nerve root should be up there in that fat. I'm not really seeing it. It's buried. Okay, we're going to be switching from disc surgery to facet joint surgery. And we're going to treat her painful facet. First, a little antiseptic, a little betadine. We'll clean it out.
We have another question.
Happy to take the question.
This comes from Stax once more on Facebook.
Hello, Stax.
And they said, thanks. I've had a L4-L5 annular disc tear and a mild bulge for 7 years, and it hasn't healed. How do I know if I need surgery?
Hey, Stax, you need surgery. You just told me how. You gave me what I needed to know. You have an annular tear with a bulge that hasn't healed. We know they don't heal on their own. And I assume you have pain. If you do have pain, and that's the reason why you said it hasn't healed. If you have any pain, that means it's coming from that tear and that bulge. This surgery you're watching is the surgery to fix it. It's the best surgery in the world for that problem. So you need surgery. People ask me this question all the time, Stax. It's a great question. How do I know I need surgery? Here's the answer. Your problem will never heal itself. Your problem will never heal with physical therapy. It will never heal with chiropractor. It will never heal with shots or injections. It will never heal with medicine. There's only one way in the world to get rid of that pain from that tear, and that is surgery on the disc. Now, if I did the Deuk laser disc repair or I did a fusion, either one would work. But you have to have the fusion done properly. Now, who wants a fusion? Nobody. Right? Why would you have a fusion when you don't need it? This surgery is far better than a fusion. So the answer to your question is, if you're having any symptoms, pain, discomfort, then you need surgery. And I'd say that to every single person with a bulging disc and pain. They need surgery. Now you may say to me, well, the pain isn't that bad. Well, if you don't mind the pain, then don't get surgery. But the only way you're going to fix it is with surgery. You may say, well, it's a small herniation, but I'm in a lot of pain. Do I need surgery? You need surgery. That's the only way to get rid of that pain. Hold on, Jordan.
He says, yes, the pain runs to my hips and down my hamstrings.
Yeah, it's 100% you need surgery. Listen, I'm going to tell you something. The situation where you don't need surgery, when you have an annular tear and a bulging disc, here's the situation. You have no symptoms. If you can live a normal life, you can go to work every day, you can jog, you can exercise, you can go ice skating, rollerblading, windsurfing, water skiing, whatever you want to do, anything, and you have no symptoms, but you have an annular tear and a bulge, that's when you don't need surgery. No symptoms, no surgery. Now, no symptoms with an active lifestyle. But if you're laying on the couch all day so you don't get back pain, that's not an active lifestyle, right? And in that case, I would tell you, get it fixed so you can have an active lifestyle. I don't know what your plans are for life, but God, life is meant to be lived and enjoyed to its fullest. That means get out and do fun things. You can't do fun things when you have a painful disc. So the answer is, if you have a painful disc and it's limiting your life, get surgery. Get this surgery. We've done 1,600 of these surgeries. We've never had a surgery complication, okay? And we don't have infections. We don't have nerve damage, spinal fluid. This is the safest surgery in the world. It's outpatient. It's a 1-hour surgery, 1-hour recovery. And then you just got to heal up for a year, and then you can do whatever you want without pain.
You know what? You can break. You can break if you want.
All right, folks. At this point, we're going to do a new procedure that we've been doing for a while, obviously, but new for you. Some of you have never seen it done before. It's called the Deuk plasma rhizotomy. And basically, we're not going to be treating disc pain. We're going to be treating facet joint pain. That's spelled F-A-C-E-T. Facet joint pain is the second most common cause of chronic pain. And she's from Canada. She saw me yesterday. She was telling me she had pain over her facet. I looked at it. I said, yes, you do. Let's get the lights on.
Lights on, please.
So she told me, fix it while you're in there. So we're going to fix it. All right, we can see the implant is at 5-1. That's 4-3-2. 2-3 has the dye in the disc. And we're on the right side. Everybody agree right side. 5-4-3-2. Everybody agree right side.
Right side, agree, sir.
I need affirmation.
Yes, sir.
All right, let's put a little pressure in between bursts. Okay. What's going on? Nausea? She get Decadron? All right. 5, 4, 3, 2. I'm going to start with the L2. The L2 dorsal ramus, medial branch of the dorsal ramus. Shot. That's 2 lateral. Let's see, 5, 4, 3, 2. I need to be more medial and more superior. Let's see where that is. Shot. That is definitely better. I think I can do both with that. So I'm going to try to get both with one incision. This surgery here doesn't require a big incision. It's a 3mm. Shot. All right, it's the bottom edge of the transverse process. Hold on. And just so you know, this surgery here is heavily guided by fluoroscopy. Okay, so I need to do quite a bit of fluoro. Shot. All right, you see where the needle is right now? Show them. That is the perfect place. That's exactly where the medial branch of the dorsal ramus is. That's the nerve that's going to go down and innervate the facet joint. So we're going to do a little bit of numbing medicine just to help reduce the amount of discomfort the patient will have after surgery. And then we're going to make an incision. It's a 3mm incision in the skin. Then I'm going to bring my Deuk plasma rhizotomy probe in, Coker. And again, I have to navigate it. So you have to use the X-ray to find the right spot. It's not possible to find the right spot without the X-ray. 2 lateral. So I'll tell you the mistake of where we are. And then 2 lateral. And then you guys could hear me and understand how I'm changing my trajectory. Shot. All right, 2 inferior. Shot. Yeah, that's perfect, actually. I could feel the top of that TP. And we're going to treat. I'm going to, wait, don't move. Shot. That's at the bottom end. I want to be a little more superior. She's moving a little bit, so she's kind of throwing my instrument off. It's fine. But I do have to get the right spot. Shot. All right, that is nice. I could be a little bit more medial. I'm on the bone, by the way, for those of you wondering. Done. So that was the L2. Now I'm going to go to the L3. Don't do anything yet. We start by placing our spinal needle in the right spot. Okay, that's 2 lateral and shot. It's 2 lateral. I want to be a little more medial. Shot. That's perfect. Right there, go ahead. We're going to put some num-num. And once again, I want to verify the level. I can see the device at the bottom with the L5-TP. Show us the L5-TP, transverse process. Yep, 5, 4, and then 3. And we did the one above, which is 2. So we're doing 2, 3. This is how you do it. Any questions?
Yes, we have a question.
Sean?
Another question from Stacks once more on Facebook.
Hello, Staxy.
And they ask, thank you. You're
Sean?
exactly right. I am limited when it comes to certain activities. What's the name
Sean?
of the surgery? Do you accept health marketplace insurance? If not, how much is this procedure?
Yeah, great questions. First of all, you definitely want to get fixed, okay? And this is the best surgery in the world for your problem, Shot. Oh, it's perfect positioning right there. How much the surgery costs depends on how many areas we're fixing and whether those discs are they in cervical, lumbar, or thoracic?
He
I'm
said
almost done, 30 seconds. Shot.
he said L4-5 annular disc tear.
Yeah, so number one, I have to agree with you. Obviously, I'm not going to operate. This is not McDonald's. You don't show up and say, I want a Big Mac, and I just give it to you. I'm not going to operate on any patient I don't believe that I can fix them. So that's number one. So I need to look at your films myself. And once I've done that, and I agree with you, then we can price out your surgery. As far as insurances, do they cover it? They do. Most of them do. But we have to fight them to get them to cover it. All right? They're not, a lot of them won't just cover it. So we don't have a contract with the insurances, most of them. So we're going to have to actually reach out to them and bill them for the surgery. And that happens after the surgery. Now, can we find out ahead of time if they'll cover it? No, because they'll lie. They'll tell us they'll cover it, and then after surgery, they'll pay us $5 for the surgery. We can't do that because we don't have a contract. So they'll do whatever they want, and then we have to fight them. So we're going to fight them anyway, but we need to collect some money up front for these surgeries. So there will be what's called a deposit, where you're going to actually have to pay some money out of pocket. You do the surgery, we bill your insurance. They don't pay properly, we fight them. All right, I'm going to call my blood loss 2 mil. This was a DLDR. Let's go ahead and I'll come and answer questions for you guys. Start typing your questions up, and I'll do a face-to-face, and let's go ahead and run a testimonial. So this is a DLDR, right, L2-3, L5-S1. Everyone agree? And it was a DPR. Henry, you got to give me a countdown. Right. Hello, I'm Dr. Arjig Majan at the Deuk Spine Institute, and I'm here with one of my patients who's just came in for a checkup today, and she had the Deuk plasma rhizotomy. This is a new type of rhizotomy being done to treat facet joint pain. I say it a lot, but the most common cause of back pain and neck pain is a herniated disc. The second most common cause is a arthritic facet joint that's painful. And the standard treatment these days is something called a radiofrequency ablation, or RFA rhizotomy. The problem is that RFA rhizotomies don't deliver very much energy to the facet joint. So if they get the nerve, usually it's temporary and the nerve just grows back. we figured out a way to deliver more energy through what's called a plasma rhizotomy. It's a Deuk plasma rhizotomy, and you had it done about a week ago. How do you feel today?
Amazing.
Yeah?
I have zero pain. So
And what did you say to me earlier? This is the first time you've been pain-free in
years.
years. How many years have you been dealing with back pain?
Yeah, probably 10.
10 years.
It's been a long time.
And you look very happy.
I'm very happy.
Now, you did have the RFA. It worked for, gave you some relief for a little while, then the pain came back. And this feels different though.
This feels different, as in within 2 days I had zero pain.
It's awesome.
And now here I am a week later. I can run a marathon, I think.
Good.
I
Well,
mean,
we
I
want you
won't
to.
yet, but I can, so.
All right, and there's millions of people out there, and that's why we do these testimonials, really for them, not for me, not for you, but it's to spread the message of hope that there is a way to get out of back pain. You just have to stick with it, find the right place, get the right procedure, and eventually you can get there. And what do you say to that?
I say you're correct. That's Deuk Spine Institute didn't give up on me. I've had several procedures, but you kept pursuing my pain until you figured it out. So thank you very much.
You're welcome. My pleasure. Anything else you want to say to your fans out there?
To my fans, come see this man. He is amazing. Deuk Spine Institute staff is amazing. Everyone treats you with respect, and they listen to you. That's very important to me. So I just want to encourage people, don't live with the pain. Please come see Dr. Deuk and Dr. Patel at the Deuk Spine Institute.
I appreciate you saying that. The lesson here is don't give up on your pain.
Yes.
There is a way to fix it. And a lot of patients, probably about 25%, end up having more than one source of back pain. And we have to treat each source because each source requires a slightly different treatment. The rhizotomies definitely were what you needed, but you needed a rhizotomy that worked well because of all the inflammation of the facet joints and the scar tissue. And the plasma rhizotomy is the most powerful rhizotomy that can be done. It's only done at Deuk Spine Institute. So congratulations on
Thank
your
you.
new lease on
Thank
your
you.
back. All right, let's get you out of here. This is Dr. Aru Deuk-Majan, CEO and founder of the Deuk Spine Institute. I'm here with one of my patients, and you've traveled from where to the Deuk Spine?
Idaho.
Idaho, with your lovely husband, and we've had a few conversations. She came here to have her back fixed. How long have you had back pain for?
For over 7 years.
Okay. And what kind of work did you do before you retired, if you don't mind me asking?
It was desk work.
All right. And so you had back pain for 7 years. Did you have an injury to your back, or did it just kind of gradually come on?
It just gradually came on. I actually noticed it first in 2015 when I was gardening and I couldn't be up there for 8 hours. I was into it for about 4 hours and I had to take a break. And as time progressed, my breaks got longer and longer, and the amount of work I did in the garden was less and less.
Understood. And you're retired now. So what's it like having back pain limit your ability to do stuff when you're retired?
For me, it's very frustrating. I can't do that what I want to do. So we kept seeking solutions and nothing was working. They did work for a short while, but that short while decreased over time. It was shorter and shorter. My husband does research very, very well. Through his research, he found you. We read that you can fix my back, and you did fix my back.
That's right.
And I thank you.
You're welcome. So when did you have the Deuk laser disc repair done and the Deuk plasma rhizotomy?
I had those done yesterday in the afternoon. I am sitting straighter than I have. I'm standing straighter. I'm walking normal. It's like, wow, new me.
Look at that smile right there. I hadn't seen that until just now. So
Well, it wasn't there yesterday.
yeah, it wasn't there before surgery. And How long have you been not smiling because you've been in pain? I mean, really bad pain. How long has the really bad pain been there?
Well, the really bad pain has probably been over the last 5 years. It's something that was really tough to maintain a positive attitude and try to keep a smile on my face and keep Jeff's hopes up. I tend to be a positive person, but there were times when it does drag you down.
Of course, yeah. It's hard living with chronic pain, and especially with loved ones, they have a hard time, you know, relating. Of course, they want to be supportive, and your husband is a very supportive man, obviously. And he's a pleasure to meet. I know he's an author as well. Yes. And so what are you going to do? Just kidding. Sorry about interrupting the testimonial. I just wanted to get to your questions as soon as possible. We have just completed two types of surgery in one. And this patient travels from far away. We wanted to do one procedure and get everything taken care of. So when she originally talked to me over Zoom from Canada, I diagnosed her as to having two painful discs. That was the bottom one, where she had already had surgery in that area with that interspinous device that failed, and then she had another disc herniation up here at L2-3. So I diagnosed her as to having two painful discs, and they were definitely both painful. But what I didn't know she had was pain coming from the facet joint right here. And that little joint is different than a disc. The disc is there, the facet is there. And when she got here in clinic, I examined her and she had a tender joint. We sent her for a diagnostic block. We numbed the joint up with Novocaine. Same thing the dentist puts on your teeth before they start drilling on them. That way you don't feel the pain. So if you block the facet with Novocaine, it takes the pain away from the facet joint, if there is any pain. And indeed, she had 100% of that facet pain went away with the block. We knew right away we had to treat it. So we did what's called the Deuk plasma rhizotomy. And to give you an idea of the difference between a regular rhizotomy and a Deuk plasma rhizotomy, this little dot shows you what the, whoops, let me show you. Sorry,
There
there
you
it
go.
is.
There you go.
This little dot shows you what an RFA does. That's the burn radius of an RFA. That's why they don't work, and people keep coming back. This is what the Deuk plasma rhizotomy does. See the red?
Yep.
Right there? Those red flags are what the Deuk plasma rhizotomy does. Much more effective treatment for facet pain. Now, it turns out Deuk Spine is actually going to be the first in the world to publish on the actual causes of back pain and their frequency in a population of patients that are called community-based, meaning the vast majority of pain patients who have back and neck pain, they go to a community-based doctor. They don't go to the hospital. And so we've got thousands of patients that we've treated over the years, and our senior research fellow, Arias Deuk is actually compiling data right now to look at what is the most common cause of back pain. Is it the disc? Is it the facet joint? Is it the piriformis? Is it the sacroiliac? And of course, which disc? We know from preliminary data that the L4-5 disc is the most common to herniate. And based on my experience of treating patients over the years, I've noticed the L4-5 is in virtually every single surgery we've done. The L5-S1 is the second most common, and the L3-4 is probably the third. So Arias is looking at the actual incidence and prevalence of the causation of chronic back pain. And that paper we'll be submitting for publication. You should see it hopefully in the National Library of Medicine by the end of the year. But right now it's looking like disc pain represents 82% to 83% of chronic back pain. I always tell people 85% because that's been my gut feeling, but now we're going to have hard data. I always thought facet joint pain was around 15%, but it's looking like it's closer to 10%. So that means that the other 8% to 10% of back pain is coming from non-disc, non-facet joint sources in the lower back. The neck is maybe a different situation. We'll have to see because he's doing the neck data as well. Anyway, this patient that we just finished, she had both disc pain and facet pain. We treated both with this surgery. Any questions?
Yes. The next two questions come from Stats on Facebook. And they said, where do I send the MRI to? And what's the name of the surgery?
Well, Stacks, you're gonna, yeah, you're gonna send the MRI through a form that we have online. We have a MRI review form, and you're welcome to use the free one. It's mri.deukspine.com, and Henry is typing that in right now as we talk. Just click on that link. You'll see there's a short questionnaire. You need to fill it out, and then at the end of that, I don't remember if it's page 3 or 4, it'll offer you the ability to either upload your MRI images by sweeping them into our portal from your computer or CD, or you can send us a link to a portal, or you can actually mail your CD in with the images. So you're going to have a choice. Those are the choices. There are no other choices. You can't attach them to an email. The files are too big. We've tried. There are other ways you think you can transfer files, but these things are huge files, so we need them done a certain way. Once we receive your actual MRI images and the report and your questionnaire, we will schedule you for a free Zoom meeting where I'll sit there and talk to you for 10 minutes. I'm going to start by asking you questions about your back pain, and then I'm going to be looking at your MRI while I'm talking to you, and then I'm going to show you your MRI and tell you why I think you're having your pain. And then I'm going to tell you what needs to be done to fix it. And then at the end, I'll answer all of your questions. I do this for people every week. We have a huge demand for this service, and it's growing. The number of MRI review requests we get, it used to be, a couple a week, a year or so ago, and now we're at maybe 15 to 20 a day that we get. So we do this as a free service generally, unless I don't like you, and then we charge you. Okay. Or if you have a really complicated problem, we may want to charge you. It's 99 bucks. But you can use the free portal because I like you already. You ask good questions. You're reasonable and fair. The name of the procedure that you just watched is called the Deuk, spelled D-E-U-K, laser disc repair. It has been peer-reviewed and published. It's in the National Library of Medicine. It's all FDA approved. It's state-of-the-art spine surgery. It's going to be the standard of care that everybody uses in the future. The secondary procedure was the Deuk plasma rhizotomy. That's where I went in and basically did a kebab procedure on the facet joints, just so, in case you didn't know what that is. The facet joints, like we talked about, are these small joints in the back of the spine. They do get arthritis pain in them. They hurt. They're stiff and painful for certain people. There is a nerve that goes to that joint right there. And what we do is we go in and cook that nerve with a special tip of a device that destroys the nerve. It's called a rhizotomy when you destroy a peripheral nerve. And the only purpose that nerve has is bringing pain to your brain from that arthritic joint. So if we can kill the nerve, we stop the transmission of pain signals to your brain. You don't feel any pain. You go on and move your back normally. And that's what we're hoping for. So she had one of those joints being arthritic, and we fixed that with the Deuk plasma rhizotomy. What's the next question?
Next question comes from Carla, and they on YouTube.
Hi, Carla.
They ask, how far/deep does the laser go, and is it a switch? Is it a switch you activate?
Hey, Carla, great questions. Yeah. So the laser, the little glass tip, you saw that in the endoscope. That tip is 1 millimeter across, and the laser energy comes out of the tip and down off the glass tip 0.5 millimeter. That's 0.5 millimeters. Basically, the easiest way to think about it is whatever the laser tip touches, it's going to give that energy to whatever you're touching and blast it. So it's not like it shoots, millimeters or inches away. It doesn't, unless there's no water in there, then it would. But as long as we have liquid circulating around in there, then the laser energy only gets delivered to whatever you're touching, and the liquid cools everything. Um, the second question you asked me was, how do I turn it on? The answer is a foot pedal. So you don't see that, but I'm actually stepping on a pedal. And whenever it's like, you know, those video games where you push the accelerator or the brake, little pedals. We have a pedal at the bottom down there that when I'm ready to turn it on, I step on the pedal.
And lastly, we have a question from Michelle, I believe, on Facebook, and they asked, "Hi, is your method suitable for cervical foraminal stenosis?"
Hello, Michelle. And I assume it's French.
I believe so.
Michelle Mabel. I'm Dr. Deuk Majan. Nice to meet you. Is this surgery suitable for cervical spine? Absolutely. We use it in the cervical spine all the time. The approach is through the front. We come through the front. I go through the disc, and I can treat foraminal stenosis, which is narrowing over here in the foramen. I can treat that by removing the herniation that's causing the foraminal stenosis. So.
And that is it.
All right, I hope you enjoyed this. We have one last surgery today. It's a special day. This surgery will be doing a bilateral L3-4, L4-5, L5-S1, Deuk plasma rhizotomy. So, once again, this patient has pain coming from their facet joints in the back of the spine, specifically 3 L5-S1, L4-5, L3-4. And I'm going to do the rhizotomy where I kill the pain nerve right there, right there, right there, right there, and then I'm going to do the other side. And I'm going to do 1, 2, 3, 4 on the other side. So we're going to be destroying 8 peripheral nerves that are pain nerves to the facet joints in a procedure called the Deuk plasma rhizotomy. We'll be doing that in about 30 minutes.